This is a podcast where experts in movement and life tackle current concepts in health and wellness and use science and evidence as the foundation of how we discuss each topic. This is not medical advice, but a sedentary lifestyle is much more harmful, so we should move. The Motif experience, where movement and life come together. I'm your host, Dr. Tyler Cuddy-Ford. On this wide-ranging podcast today, we have Dr. Dan Kang. He's faculty here at George Fox, a master clinician, physical therapist, of course, voracious reader, true innovator of practice, as an example, bringing or embedding a physical therapist within the primary care setting. So if you're wanting to know a little bit more about what that means, working directly inside an office with a physician, Dr. Kang has started 5 of them. So this is just one of the topics of many that we're discussing with Dr. Kang today. Supposed to do that trip to the inner city. So
I think you did tell me. Go ahead.
And I had I got a motorcycle accident.
Oh boy.
I didn't tell you that?
No.
Oh. So I was riding my a good close friend's bike, and I was checking it out because he wanted to sell it. So I had a sport bike at that time, and so he had busted his back, and so he needed someone to do one last test drive before I went and traded it in. So I says, okay, I'll do it. And so I ended up wrecking his bike. Yeah, and so
Nice.
I know, hit something in the road going around. I don't remember exactly, but I remember waking up upside down in the ditch. And so I look up, and there's just these people staring at me. So not really remembering, what happened at all. And I remember going uphill.
Yeah.
So I asked them, which way's up? And I can't believe that they let me back on the bike. So I picked the bike up out of the ditch. I had a fender missing, so I put the fender on. I picked up the pieces, and I rode off.
Wow.
And I'm remembering, as these people just staring at me. I mean, they were like intent, just staring, never said a word.
Right.
When I said which way's up, they just stared at me and pointed up. And then, so I get behind this school bus, and it's right, we're a few blocks from his house. So I'm parked behind the school bus, and the kids are looking out the back window at me, and they're staring. And then I don't know how old, maybe 10 or 12-year-old little boy walks by the bike, gets off the bus, walks by, it goes, and I'm holding the fender on, right? And I think the fairing, and so, the fender fell. Because, at this point, I'm not feeling well.
Yeah.
And so I asked him, dude, could you help me?
Yeah.
So he grabbed and he's like staring at me like this. And he bends down without even moving his eyes from me, and he picks up the fender and gives it to me. And then I get to my buddy's house, and I look in the mirror.
Yeah.
Well, I had ripped my nose off.
Wow.
Yeah, so my nose was tore off. Well, not off. I mean, the whole side of it, and it was just blood is just gushing out. I had pierced my chest with the fairing, so I had this hole in my chest here, and then I had this where I went through the windshield or the fair. I had this cut on my face. Well, that was on a Saturday maybe, and I'm heading to New York to do inner city basketball.
Yeah.
And so this is where I met, Fat Joe and 50 Cent, the whole baller group, and trying to understand, the culture of Nike basketball, and so so it was perfect because I totally looked like I got into a knife fight. Because I had the stitches, I had a plastic surgeon. He stapled it, stitched up my nose, stitched up with this, fine. I mean, it just had a black eye. So when I'm in there, it looks like I am serious with playing street ball. So that was kind of a fun story.
Yeah.
And then we went to Compton and did some stuff at LA and in Chicago but
no one messed with you then. Huh?
no, it was so great. It felt like I had instant credibility.
Exactly.
Even though it was dumb.
Exactly. It's a great story. Did you have to pay for the bike?
Oh yeah, that was $10,000. That one hurt.
Yeah, I was gonna say, doesn't sound like a cheap accident. Right?
Yeah, it was not a cheap accident.
That's the worst part. It was
I know.
alright.
It was
This
the
will
worst.
bruise. I mean, this will heal, right?
Heal, yeah.
Yeah.
So.
It's fun.
Yeah.
Have you always had a high pain threshold?
Oh, have I? Yeah.
Because most people don't walk away from that. Most
Yeah.
people call the ambulance, or they sit there and cry, right?
No, I think I have, and so I don't know why we're into this. I think we're gonna get into some of that.
Yeah.
So here's a bone pin. So I think our viewers can see it. But
Yeah.
how can I have these inserted in our femurs and our tibias? For our dissertation validation study.
Yeah.
And so I think that at some level, I kind of always had a kind of a high, pain threshold.
Yeah.
Yeah, tolerance.
Do you think you understand people who have low pain threshold then? Because, that's one of the challenges, right?
So I'm supposed to be asking you questions, so I'll answer this one. So,
Do you think you can relate with people who have low pain thresholds?
up until maybe, until I met you, and we started doing primary care,
Yeah.
and you and I started to try to change, have an impact on our community,
Yeah.
I would have said no.
Yeah.
And so here's my father-in-law. I think he'll be okay. Stubborn. I'll call him out. He's German. He goes to the dentist and
Yeah.
has no Novocaine.
Wow.
And they drill and do everything with nothing.
Wow.
And then I won't mention, but there's someone in our family who, when you call him and he answers the phone,
Yeah.
Hello.
Right.
He has a cold.
Yep.
Right, so there's two extremes, and so I don't know that up until a few years ago, you're probably right. I didn't understand those that had this, less tolerance to pain.
Yeah, me neither.
But Stephen George's work.
Yeah.
When he was talking to the,
Yeah.
the tattoo artist.
Yeah.
That was powerful.
Yeah.
Understanding that, and that the article we talk about,
Yeah.
where the pain really is more related to fear
Yeah.
than it is to an actual event.
Yeah.
Yeah.
So, that's interesting because, we're kind of getting on the topic of pain, and I think it's really complex,
Yeah.
So, I don't know. I think a lot of people right now are trying to figure it out, on how to treat pain, and I think they're doing the best they can.
Yeah.
But I think the hardest thing right now is, there's been one thing that everyone's kind of clung on to, right, which is pain education.
Right.
And it's something that you and I really haven't jumped all over.
Right.
Why do you think that is? Why do you think we're always like, and I know, I'm not supposed to interview you, but I find your perspective very interesting because,
Yeah.
I think that, my personality will come out, but it's like, I've just been so interested in how I know why you got into pain because you wanted to help the community, but how do you see pain and treating someone with pain? Do you see it as one of those things where you're going to expose, you're going to exercise? Is it more communication of pain?
Yeah.
What do you think it is?
I think what flipped me, and this will be I'll ask you after I answer,
Yeah.
what flipped me was, kind of this geeky neuroscience approach, between the Lumberg and the Sheraton model.
Yeah.
Once I realized that it's real for people,
Mm.
because I didn't realize that, even as practicing, and even later on.
Yeah.
I don't know that I realized for them it was real.
Yeah.
And so I just thought they were low pain threshold.
Yeah.
Right? Or, oh my gosh, they're just babies.
Yeah.
And so once I decided, amongst myself that it's real, based on, fear,
Yeah.
relating much more to pain than the actual intensity.
Yeah.
I think that's when I flipped and thought, okay, so how do we make it real?
Yeah. That's true.
So I know when you go into, I've had lots of opportunities. Well, we've had lots of opportunities to practice together.
Yeah.
Be in the same room, and I'm interested in what lens you're looking through when you walk in, because these pain. See, I fear that what's happening in current practice is that the lens of the biopsychosocial model is what people are looking through, and so they pick the psychosocial, and forget bio. When the pain, I think pain is less hot than it is now. So let's say 4 or 5 years ago, when it was really at its peak, therapists would walk into the room with a particular lens on and say, okay, I'm here to address your pain. And but I don't see you do that. So what lens do you use?
I think that's a good question. I think one of the things is that there's different ways that people learn, and I'm very I learn mostly by observing. I don't know if you ever watch me, right?
I do.
I like observe things.
You do.
And
you're quiet.
Yeah.
When you're in the interview or doing the initial intake.
Yeah. And I've observed a lot of therapists actually.
Right.
So when I'm observing the patient, it's one thing, but I've learned how to observe other therapists, other providers, other physicians. Doesn't matter. I just observe them and see what happens. And I really was turned on by in the beginning of my career. Manual therapy, and I watched that, and I love the pain modulation, especially the high velocity thrust, right? So I spent a lot of time learning that technique, doing it over.
Did you know that it was pain modulation early on?
No.
Okay.
I thought that what it was doing is what I think we're trying to figure out now.
Right.
Is that it was an alignment issue.
Okay. All right.
That I was working on alignment, or there's a mechanical issue that caused most of the low back.
Yeah.
And so I was more focused on facets and SIJ dysfunction and discs. So I was very structural in my approach.
Yeah.
And a big fan of the clinical practice guidelines.
Yeah.
And so I followed a lot of the clinical practice guidelines, especially the manual therapy standpoint. I really enjoyed that aspect. So I spent a lot of time around that. But what happened was, when I was in private practice, I had so many patients respond well, but I also had a lot of patients who didn't respond well. But the crazy thing was, just like with you, they were still willing to pay me because they loved the conversation. They loved the I don't know, they call it a spiritual connection with me, or whatever you want to call that, right? I mean, just a really deep connection with each other. And they always were so grateful. But it bothered me that I was making money and I wasn't able to help others. And I didn't have a hero's complex. I think it was more of a frustration. Like if back pain was mostly mechanical, why isn't that fact that everyone's getting better from, not even from manual therapy, but like fusions and injections? That really kind of started playing around with my whole understanding of back pain. And I just kept asking myself that question over and over and over, like, what is the 40% I'm not understanding, or the 50%? And
so do you remember when, so now that you're reflecting back, right, in clinical practice, and because we've had this conversation, you were more classic, high velocity thrust technique. I was more DO trained, so that, another approach. And I guess and I was, practicing, and I do it wrong. And people still got better. Right. So, initially, you put them in the wrong rotation. And then, I don't know, initially I was so worried that you were going to make it worse because you're moving them in the wrong direction. And so I remember that, as a young therapist. So is this a reflection for you, or do you, as you were deep in the woods with that, do you recall at times when you were doubting?
I didn't doubt until probably like my 6th or 7th year.
Okay.
I was deep, and I think what made me really deep was the fact that I was financially incentivized to believe in it.
Got it.
Because I was one of the first physical therapists in my area to actually be doing high velocity thrust, doing a lot of soft tissue, doing a lot of hands-on. So when I came into town, not too many people were doing that. It was more exercise-based, aid work. So I had a clinic that only was physical therapists. And so I was incentivized to actually get patients, to put my hands on patients. So I was completely sold that this was the only way. What happened, though, is I started to, I don't know if it's okay to say, but I started losing the curiosity. it started becoming like,
oh, yeah.
you know what I'm saying, that curiosity.
Yeah.
I was no longer curious anymore. It was more like, I got 15 patients coming in, and I would start doing the math on time, and then I would do the math on financials,
Yep.
and I would start thinking of it from that standpoint, like how many patients can I do in a day?
Yeah.
And that's not really why I got into PT, right? I got into PT to do something else than that, but that's where it all headed for me. And when I started losing the curiosity, and I started looking at it from like a time management and cost benefit and all these other things, that profit and loss margins, I knew there's something wrong.
Yeah.
And so, sure, we were, financially successful, but internally, I was probably bankrupt. Like, I was literally bankrupt.
So you got curious again, because I remember getting a phone call from you out of the blue about 10 years ago.
Yeah.
Right, just 100% out of the blue.
Yeah.
And so what got you curious again?
Yeah, I think what got me curious again was, you know how like when you start losing that curiosity, or people would even call it like a midlife crisis,
right?
You start like going back to your high school years, and you'd be like, oh man, you remember in high school, Tyler, right? All of these things, and I think what it made me think about was, why did I go to physical therapy school in the first place? What was my real first love look like? And when I saw George Fox's thing pop up, I mean, it was really, it was kind of a spiritual experience for me.
Yeah.
Because I was kind of in a rut in my profession, even though I was doing well in lots of other reasons, other things. But I knew that a change was going to happen. You just know, like, successful people don't stay at a place that is dry too long.
Right.
It's not part of our DNA. And I knew I was moving, and I knew that something was going to happen. I had like a date with like a move, like some type of trajectory that's different than I was in. So I was thinking maybe it might be starting a second practice. I thought maybe a career change. So I dabbled a little bit in education. I didn't really like undergrad. It's not really who I am. Yeah. I'm more of a kind of a sergeant type or a mentor type, not someone that's teaching at a earlier level. So I didn't like that. So I kind of gave up the whole education, and then George Fox popped up, and I really sensed this strong calling that I was supposed to call that next person in line, and that's when your name came up. And I actually Googled you, and it just had a goofy picture with your Hawaiian shirt on. I think it might have been like a promo, right, of the thing. I think it was a Hawaiian shirt, and I looked at you, and I'm like, oh, who is this guy? Because I kind of know the manual therapists in the West Coast, and I didn't recognize your name, right?
Right.
Because I didn't know your story, being at Nike and being from Iowa, so I didn't know who you were, and I was like, I can't cold call this guy. He's gonna think I'm a freak, and but I kept having that sense,
yeah,
and I decided to call you, and the thing I liked about you the most, Tyler, honestly, when I met you, was the fact that you impressed me. It's like I told you I was private practice. I told you, and I say I was successful, but I think you, like, this guy's pretty confident. He's just cold calling me. We've never met each other. And I said, and I told you, like, I felt like, God called me to call you.
Yeah.
And and I said, I remember I said, PT school changed my life. And I said, and you're going to change so many people's lives. And it was weird. You didn't try to pull me in at that time. But I think it was the invitation you gave me later on as we began to know each other.
Yeah.
Of like saying, why don't you come and help us, right? Make that change for other people.
Well, it was refreshing for me because I remember I get those phone calls all the time or emails or something.
Yeah.
Hey, I've been in practice 20 years and I'm getting tired and I want to teach now.
Yeah.
Right? And so I don't know. For me, it was refreshing because it wasn't that call.
Yeah.
And it was really about, hey, I'm with you in this journey.
Yep.
Even though I'm from California, I'm going to give you all the rooting I can.
Yeah.
And for me, it was refreshing to know that you weren't looking for a job. So,
No, I would tell you that thinking about it, because I was living in my hometown. Just thinking about uplifting and you probably I always tell this story. It's like my wife and I just bought our our home and and it was kind of our dream home, and so in no way right were we looking to move out of Southern California and the area that we were living. It was always my dream to stay there, but I think dreams change.
Yeah.
I don't know
Yeah.
what you believe in that, but I think dreams change, and I think that I would have been extremely. I hate to use the word because I never use it. As I think I would have actually gotten bored.
Yeah.
You know, I was kind of heading towards that direction,
Yeah.
And I knew there's danger when I get bored. Like I have been bored in my life previously before going to PT school, and I got into a whole bunch of trouble.
We're a lot of alike that way. When I get bored, I get in trouble.
Yeah.
And so either, so that's been my MO. When
Yep.
I just are not stimulated enough.
Yep.
I get bored, and this place has allowed us to kind of not be bored,
Yeah.
and do things. And we've got some big things coming up with a new clinic and a new building, and
Yeah.
kind of rebranding what that
Yep.
looks like. And
Yep.
JD's right here, and
Yeah.
she's our computer person. So if we have a question,
Shout out.
shout out. Well, she'll be
JD.
she'll be giving us some answers if we
Yeah.
have a question.
Yeah.
But I'm interested in when you flipped.
Yeah.
So and it may be the same time. I may have flipped earlier, but I didn't know what to do with it.
Yeah.
But it was that journal club. It was the boot camp.
Yeah.
When we all read that article together.
Yeah. 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 I think I was flipping before that because.
Let's talk. What the Vibe Furman.
Yeah.
Right. So
Yeah.
is the author.
Yeah.
So 2013 or 14 paper.
Yeah. That's right.
On manual therapy. So it was a randomized controlled trial with.
That's right. Norwegian manual therapy.
Yeah, Norwegian manual therapy is
20 years.
30 year
Yeah.
experienced
It's-
crackers, right?
Right.
And so these guys can manip.
Yeah.
And two groups,
Yep.
right? A exercise group, and
Yep.
then a cognitive functional therapy group.
Yep.
Well, we both know
Yeah.
the CBFT one.
Yeah. Absolutely.
One big with nondescript low back pain.
Yeah.
So.
Yeah, I think that it was when you because I've always been kind of interested in low back pain, and I was still trying to find my identity as a professor. Tyler hasn't told you, but like every year I would wonder if I was going to come back. So one of the things that I try to do is I have a tendency to target things, and I don't target to be the best. I target to have like impact.
Impact, yeah.
It's not I don't compete with anyone else except for myself.
Right.
But I try to have the greatest impact that year that I possibly can. And every year I felt like such a fish out of water because I didn't know how I was going to impact things. And I think I was taking on other people's personalities that I saw that I respected. I was trying to figure out how to teach, really. And you never gave up on me, man. And that's the thing. You always supported me. You always mentored me every week. And the thing that really flipped me is when you told me we were practicing together, you saw me practice, and you're like, if you can just practice the way that you do in the clinic, just teach the way you practice, Dan, and we're just going to be just fine. And I remember thinking to myself, I think I said it to you, you're crazy, you know that. Because no one really practices the way I practice, I think, in the clinic. Because I practice like a madman, right? Mm-hmm. But then you gave me permission to actually practice the same way to educate in the classroom the same way. When you said that to me, a light bulb came on inside of me, and I said, is it possible to actually, and I think I said it to you, it's like, is it possible to teach the way you practice? And you said, if you can do that, you got it. And so I just decided, and then I think I asked you for a real significant action plan. And I think you said to me, Dan, you just read 150, if you read over 150 articles or whatever it was a big number. You said, that's how you'll know something about the topic. And so I just started reading. It was like 149, 148, 140. Right. And about halfway through, we read that article on CFT. And I looked at my wife and I said, I looked up Peter Sullivan's name, and he was coming down to San Diego for the San Diego Pain Summit.
Yeah, I remember that.
And then I said to you, I think it was 2 weeks, it was going to be a little expensive.
Yeah.
And I said to you, man, I know it's going to cost a little bit because it's a little short notice, but he's coming and I have to go. And I there was nothing that was going to stop me. I would pay it out of my own pocket. And you're like, no, don't do that. I got you. And I went down and I watched for the first day. And I've gone to hundreds of Con Ed courses, and I usually end up halfway through, I'm
bailing.
I'm done. Right? It's like, no offense.
Yeah.
But I'm done, or I'm kind of on cruise now because I've seen it before. There's nothing new. And when I saw him talk and saw him actually, he did a case study in front of us all. I was like, okay.
Did he really?
Yeah,
Oh.
he did a case study. His lecture style was interesting. You know,
Yeah.
he was going after, you know, imaging and posture and all the things that, you know, was in the papers, which, you know, you and I have already read. But the thing that was interesting was how he pieced, how his narrative was, how he pieced the story together, but also was able to implement, you know, the bio with the psychosocial.
Yeah.
And that's what really made me understand, okay, this is what he's doing. To the point where I knew I had to have a conversation with him. I think you should never bother anyone who's doing Con Ed, because we've given Con Ed, it's tough, right? Because we're busy and you don't want to bother someone, but I knew I had to talk with him. So that next morning I went up to him and I just asked him if we could have a cup of coffee and just had some question, and turned out to a 3 or 4 hour discussion, and just really enjoyed his perspective.
Yeah.
And I think the best thing you can do when you respect somebody or do the perspective is to study the work. And so I've read, you know, more than you know, Peter Sullivan's work, but you know, all the works around that, but also been able to practice it, and then also to implement it here and at the practice, and then teach it at a boot camps and seeing how that goes. But yeah, I mean, I think, you know, I think about this often. What would have happened if I never contacted you? I mean, I think about that. I mean, I'd probably still be I still would probably be in California. I think that's where a lot of our people who might be at right now is like, they know that they've lost their curiosity, or they're burnt out, or whatever you want to call it, right? And they know they got to take a next step. But I don't think many people do.
Yeah.
That's the thing I see. And I see that a lot, sadly, when I go to clinics and I visit. I see a lot of people who used to be so like intrigued and so interested in our profession. And it's not just PT. I mean, I think it's all careers, but I see this a lot, and they know they have to make a shift, right? And maybe it means, you know, they have to move their family to Newburgh, Oregon, right? From California. I don't know, but it's like they're not willing to do it. And I think I would say that it was probably the hardest thing, but I would tell you in every single way has deepened my understanding for so many different things, especially my faith. Living out my faith, but also like my purpose and my mission on what I'm doing. And it's still, I would tell you that if you're at that place, you really need to consider doing it. Like, I really think about that. And you probably thought that as a program director, or because you weren't in academics either, right?
I wasn't. I was in industry for 10 years, right? And same with you. It would be the equivalent where just out of the blue got a call, you know, from the dean.
Yeah.
And, you know, it was time for me to jump as well. You know, I'm wondering, you know, about the alumni that might be listening, or just, you know, young therapists, you know, about... you know, they're in the grind right now. You know, and it may not be exactly what they were hoping for, and you know, reimbursement's getting a little bit tougher. It's the climate is, you know, hard as a therapist. You know that. We're fortunate here not to have to make a ton of money in our clinic. You know, so we can do things a little bit different, and, you know, get away with some of that stuff. But I'm wondering about you know, one of the purposes of this was really, you know, to I feel responsible for continuing dialogue with our alumni, and I can't meet them all anymore. And so, you know, this was really an attempt to say, you know, what can we do for them? And so, you know, we talked about an article, and maybe we'll, you know, talk about another one or two, or maybe we've talked about 2 or 3 already. But you know, since you brought that up, you know, so what can we do to help our alumni would be my question to you. What can the alumni do that are trapped a little bit? You know, they're maybe not yet in a bad way, but they're a little anxious on you know, what's next for them.
You know, I've talked to one of our first year alum who graduated the first year, right? And she was in I believe like a mom and pop practice. And then she told me that she knew, right? She had to make a change.
She knew.
She knew, right? So we've connected just recently, and she was telling me she was so excited about the role that she took with the hospital system, right? And how she's taking on students where her other place she wasn't able to do that. How she would like to get back. I think that's actually as brave
Yeah.
as what I did.
Well,
You know what I'm saying, right? 100%.
Yeah, I'm glad you said that.
Yeah.
You know, because not everyone. I jumped.
Yep.
My girls were 1 and 2.
Yep.
We decided to move to Iowa.
Yep.
No family, no
That's right.
nothing, no support.
Yep.
You know, and so as a matter of fact, Heidi was really our kids were the only grandkids for Heidi's folks, and. So I mean, it was amazingly hard for. I guess I'll get a little personal here. Heidi's brother had just passed away at 34,
Wow.
and now I'm just uprooting everything, you know. And so that was hard for us to do that. But and I get that. That is a hard decision. You know, the decisions for. So I think that might be some of it. Where that decision, it's not meaning. I mean, it's not a big decision necessarily, but making that decision to jump, to do something different, to re-engage in a different practice area or pattern.
Yep.
I think that's important. It's not Con Ed.
Yeah.
I can tell you that right now.
Oh, yeah.
I do have a chance to see some of our alumni CVs and chat with them, and it's not Con Ed.
Yeah.
And so if they're looking for something. Well, that's not necessarily true. There are some very good Con Ed courses, but the practice patterns that they're learning in some of these Con Ed courses are probably not the answer.
Yeah, no, I agree. I tried many Con Ed courses, and it left me excited for a short term.
Right.
But then that deep seated just desire wasn't filled yet, and I don't know. I think that if I could have told my younger self something, I
like this.
I probably would have said to myself, "Don't be afraid of the difficult." Mm-hmm. You would be like, "Oh man, you're like one of those guys who you're twisting your mind all the time, so you're not ever like comfortable." But I would say to you, when I was younger, I think that I really enjoyed routine. I had this dream. I'm gonna get a little personal too. That I had this dream of having a white picket fence. And like honestly, owning my own home, right? And this spot, and when I got it felt great for a moment. But I just wanted that, and coming to Oregon was anything but a white picket fence for me.
Yeah, right.
Never thought, right? I'm a SoCal boy, 100%. So I think that one of the advices I give people is the big move may not always be the best move. It's the move that makes you feel uncomfortable. I think that some of them will have to reevaluate the things that are important, the most important to them.
Yeah.
Right. For you, it was leaving a secure job. We already had some publications, but moving to Iowa, right? I mean, it was there's more personal things, Tyler, that I think it was then professional. I think a lot of our alums are dealing with. I mean, I know for me with COVID, especially, right? There's a lot of personal issues,
right,
that you have to work through and not to run away from,
right?
But and I don't know if you ever hit it on the nose. I think it's just one of those things that come at you. So I don't know if you're coming at it or if it's coming at you. You have to be ready though, and I think that's one of the things that you and I have been able to do. We've been able to see how to maneuver around it or through it or above it. And I think a lot of our grads or our alums and our students are at that point.
Yeah.
And people call it leadership, but I don't know if that's leadership, man. Leadership is like when you're taking, like, this is personal leadership,
right?
Like when you take it on, it's like, how did you know, like, you were going to go to Iowa? Right. I mean, I know you had other offers.
Did.
And you could have stayed on the West Coast, right? And
USC. I had an offer at USC.
Yeah. So what made you go to Iowa then for you?
Well, then, oh boy, personal things as well as practical, and then also professional. The USC job was part-time.
Yep.
And so I'd have to work part-time, and then go to do the PhD program part-time.
Yep.
Baylor College of Medicine was wide open,
great.
And so there was a research position there that I was given or offered, but then I would have had to go to school part-time. And work full-time.
Wow.
And then but then Iowa had a full ride academic, so I didn't have to really work. but sacrifices for sure.
Yeah.
I remember, we didn't go out.
Yeah, exactly.
That was it.
That's right.
We rented things from the library because it was free.
Yeah.
Right, and so so it's just a different time of life for sure.
Yeah.
And even when I left Nike, it was I thought I was going to go into PT.
Yeah.
I was a little. I had a great experience.
Yeah.
Traveled the world. They treated me well. I was able to do a lot of cool stuff.
Yeah.
But it just wasn't me, and so I thought I was going to go, kind of change the world in a little different platform.
Mm-hmm.
But then it was commercial printing.
Yeah.
Right? So
Exactly.
That's not what I had in mind.
Right.
When doors started to open.
Yeah.
Anyway, that's a cool story in itself. But
for me, the biggest jump was trusting that I should be part of the team. See, what I learned.
I remember you saying that. Yeah.
Yeah. So what I learned a long time ago was that I have a team. It's me, myself, and I.
Right.
So I've learned how to be pretty self-reliant. Why I opened a practice literally a year after I graduated from PT school by myself.
Right.
Right. I did. My wife she's been amazing, as you know. We're so close, but
right.
I don't run with a group of people, especially physical therapists. I pretty much do things that I feel is right. And when I met you, I don't know. It was a different kind of experience for me, and I think what I was learning is that saying, right? Is the fact if you want to go fast, you go alone. If you want to go far, you go together. And I didn't know I was looking for a group of people to do this with. But you, and then when I met Andy, Andy was probably the smartest guy we have, bar none, right? I mean, he's like I don't know what all of his PhD and fellowships are. He's a Fulbright. And the thing I love most about Andy is that he's not in my area of interest, really. I mean, he's a neuroscientist, by trade. And so I love that. And he's an anatomist. And so we have some really rich conversations. But it was really Jeff who made me want to come here. And, his story, and if you and I reflect on it, is the fact that after I came up here for an interview, and I thought I killed the presentation. Jeff said, "I want to meet with you alone," and I thought he was going to reward me and pat me on the back. And we shut the door, and he wasn't here. We zoomed in, and he basically asked me, "Why are you here? Right? Like, you shouldn't leave your private practice. Sounds like you've been really successful." And him and I knew some people in around the way.
Oh yeah.
Joe Goggins and them.
Yep.
And so he knew that that I trained with him and worked with those guys, and then he was really not for me to come here. And I knew that if you asked him, he's going to say no on me, right? And I think maybe he did say no, right? I mean,
all right, so I'll throw him under the bus. Yeah. Oh yeah, he says no.
Yeah, no experience, right?
Yeah, no experience. He doesn't have a PhD. Yeah. I don't know that he's going to help us.
Yeah, exactly. And I felt that. And I remember the question he asked me. He said to me, what's your research? What's your research or your scholarship? And I said, I don't have one. And he's like, what are you doing here? And it was so funny because I was thinking this is exactly the type of people I need to be with. Because I've always, how you get kind of a little bit successful? You start getting some yes people in your lives. You know what I'm talking about? Like, I don't know if people have that right now, but it's like you get a little successful, you become a director, or you become a senior therapist, or even if you graduate from Fox, people look up to you, and you start getting the yes people. I started having maybe too many yes people around me. And I knew I was getting soft. I knew.
Yeah.
And maybe that was the real rub you were saying. People love to create their own kingdom. But that's not what I signed up for.
Right.
And when I met you and Andy and Jeff, and then of course Marcy and Paul, it was great. The whole group was great. But it was Jeff that made me want to come here. He made me want to come because I really didn't need to leave. And when I always thought about Jeff, I said either he's going to break me or he's going to make me a better person. That's what I believed. I really believed that. And you told me that he's the type of person that loved to collaborate. That's the thing. Because I remember you and I were driving something, or we're talking, and you were like, Jeff, I knew you were trying to smooth things over. Because it wasn't like we were butting heads, because I really didn't have a platform to butt heads with.
Right.
I mean, Jeff was the big dog at that point, right? And not to say he was trying to leverage that, but he was. We all knew. I mean, he already had lots of publications, right? $1 million of grants or whatever he had, or $500,000. Like, he already had those things. He was already up in the higher career, and I had nothing. And so I wasn't butting heads with him. I just knew that he was either going to break me or he was going to help me get to the next level. And I knew that you and Andy were supportive of that.
Yeah.
You told me. Like, I knew you supported whatever you saw in me. Like, you supported, because you really shouldn't have hired me. I mean, my wife and I talk about it all the time. It's like, I had nothing, but you saw something that you took the chance on me. And I'm always will be grateful for that. And but community is a huge part of my second part of my life, and I think now it's like my job is to actually create bridges.
Yeah.
You know, so like for clinicians, for alumni, for students. I mean, I feel like that's my impact factor. It's like I just try to make bridges everywhere I can, and what I make the bridge to is evidence-based practice. So I'm always reading. I always love clinical decision making, and then being a clinician, but also the understanding of like education and innovation and some of the primary care work we're doing together, and some of our partners that were out there. So that's kind of, you know, like, I guess we're kind of up to speed now on where I'm at this point in my career, and what I'm thinking, and how I've evolved maybe as a professor and as a person. I remember Jeff and you said something to me. I think you said to me, and Jeff said, you know, we're excited about the time you start making a team yourself. And I feel like I'm starting to make my own team to help support our vision. And I think it's becoming kind of like my own pod. And I think it's really fun to see that occurring naturally. And most of them, of course, as you know, are alumni of our program, but we also have partners that are out there who've just completely wanting to flip the narrative, right? Yeah. In pain, but also in primary care.
Yeah, I mean, those are our biggest partners, and I'm thankful for you wanting to take on that leadership role and moving, because you know, I would have loved to do it. Because my experience in primary care alongside you and Lizandre, what was actually the most fun I had in practice.
Yeah. Me too.
Is in primary care, working right alongside the physicians and making big boy and big girl calls.
Yeah. That's what you like the most?
Oh, I do. You know, and getting it right for them, so when they leave, they're better.
Yeah.
You know, 20 minutes.
Yeah.
They have some hope to be able to move forward with the things that they came in for.
Yeah.
And to see it immediate happening, that was for me. That was a big deal.
Yeah.
So I'm glad that you're moving that forward. You know, the primary care stuff, because it's gonna be special for us to kind of keep getting data and training therapists, and you know, we've got a handful of alumni now. You know, that are leading the charge in 3 or 4 or 5 different locations. And you know, I think the outlook is very positive. Yeah,
absolutely. Yeah, the group that we're working with right now, I mean, the fact that they're going to be launching another location in January, right? And that they're looking at maybe 20 more in the future. And a lot of it is based upon the research we've done in the last few years, and it will, I think, more and more, right, on the data we're doing. And that just, I feel like it's just the right road. But, you know, my favorite story around primary care, well, I have 2, and you can tell your story on. I love the story about the big one you had with the wheelchair, but before we go to that one, is we had a new grad who was graduating, and he had like 2 choices, right? He had primary care because he did the rotation.
No, I
right?
remember.
Remember? They're launching primary care, and then up in Washington, and then he also did a rotation through an outpatient clinic where they wanted him to do a residency. And it was hard for him, right? And he was making all these decisions, and we were praying and talking, and he called me, and I remember just having a profound conversation. I said to him, you know, if things don't work out in the primary care, I said to him, I was like, you can just go to residency next year, right? He started laughing. He goes, yeah. But I said, I don't think you will, because I think this is the right practice for you.
Right.
And, you know, 3 years later, right, we know what's happening with him, and he's killing it. And
he is killing it.
Yeah, and I think I remember really asking myself, because you know how you give people advice, and you're like, is this the real advice, or are you just BSing, right?
Yeah.
And I remember going like, this guy's life is dependent on some of the conversations we're having at this moment. like, is he going to do residency, or is he
Yeah,
going to go
yeah.
to this new position that no one's even heard of? And I remember he asked me, he's like, so I have you and Halk and Cuddy to rely on, right? And so we always got your back.
Right.
I remember him asking me that.
Yeah.
Then he's like, okay, then I'm in. Like, that was one of the kickers for him, was the fact that he needed to know that there was going to be people to support him
Yeah.
with a new program.
Yeah.
And I would say that now he's supporting us. He's taking on students.
Yeah.
Right? I mean, he's like kind of
Yeah.
the leader in primary
So
care.
that's such a great story because, we're interested in what the alumni need.
That's right.
And so this is, the genesis behind this. Now we're, kind of being for full circle again. And,
Yeah.
we're going to ask them to, to reach out and, and figure out what kinds of things is going to be important for them.
Yeah.
We have some snapshots with
Yep.
some alumni, and
Yep.
some pop in and occasionally, and
Yep.
you have your Rolodex.
Yep.
For those that don't know what that is, it's the
Exactly.
it's the it's your address book in or your contacts,
Yep.
contacts, right?
Contacts.
In your phone, but.
Yep.
So it's nice to get their feedback.
Yep.
So I would welcome.
Yep.
More alumni feedback about what kinds of things can we help them with,
Yeah.
with related, that's related to, practice.
Yeah.
And how can we help them jump if they
Yeah.
need to jump? How can we help them synthesize
Yep.
articles? I think you win. So not that it's a contest, but you have taken the reading seriously.
Yeah.
And you're well read and well informed and well positioned, to be a leader in these areas because you know the literature and what it says.
Yeah.
And you're by far the number one faculty I get articles sent.
Yeah. Yeah.
From you
Yeah.
because I know you're reading a ton. So. That's one idea. As far as maybe the next time we meet, we can talk about a
Yeah.
handful of articles.
Yeah.
And what that means to you in practice.
Yeah.
How do we,
Yeah.
how do we use that for for getting. How do we use information?
Yeah.
I had a conversation with a clinician.
Yeah,
It
that's
was
huge.
he was a TAI person,
Yeah.
PACE.
Yeah.
Legit.
Yep.
Started his practice, was at Adidas, so I don't think that gives him away, but maybe. He says, "Well, what's the use of clinical practice guidelines?"
Sure.
Not that he was opposed to it, and so we had a great conversation around what that means, and I used the Achilles tendinopathy one as an example, and I said, how many patients with Achilles tendinopathy have you seen this year?
Yeah.
And his answer was one.
Yeah.
Because they're not that common, or two,
Sure.
and so, and I would ask that for anybody.
Yeah.
But what that does, so there's 1,000 articles we synthesized as a group, a team of us, looked at 1,000 articles.
Wow.
Narrowed it down to 300 and something, I think, in the, clinical practice guidelines on Achilles tendinopathy.
Yep.
And so it's as if you've seen 1,000 patients.
Yeah.
Because you can read and know what to do.
Yeah.
Now, is it going to work for everybody? No.
Yep.
Because none of those studies showed everybody got better.
That's right.
But it gives you a platform to then discuss and talk about what's real.
Yeah.
And that's what I liked about how much you've read, because now you have a base for how to treat, how to have discussions, how to incorporate the psychosocial component in with the bio, how to. How you some of that is just you as a seasoned therapist that walk in and, like you said, you observe and just you let the patient just talk, and then from there you can know right away how they move and the stories that they say, what their real challenge is, and I think you get it. You can come to that conclusion pretty quickly. I loved the last patient you were talking about this week. Super complex, right? Had seen PTs all over in chiropractic and other care, non-traditional, care, complicated scenario as she came in. But you listened in that first meeting. She believed you, bought in on you, listened to her. And in a few short sessions, changed her behavior, changed her outlook, has hope, in all those things, and that's it's because in part is because you at some level knew how she was going to respond.
Yeah.
Because of all the stuff you've read,
Yeah.
you at some level, and your experience too.
Yep.
But you were able to really quickly narrow down what that issue was for her.
Yeah.
And I think that would be something that we could talk about.
Yep.
How do you do that so quickly?
Yeah. Well, I think that the thing that's interesting is that I think that our outcome measures right now is really helping me like hyper focus.
Okay.
So I see outcome studies different than most people. So a lot of people see outcomes as kind of a baseline to get reimbursed or like how good they're doing.
Right.
I'm going to tell you some things. Like, I'm a pretty humble person, but I know when I'm doing good and when I'm not doing good. And then you know that. Like, you'll be in the clinic with me and I'm like, I'm killing it right now. Or I'm doing terrible, right? But the outcomes help me recognize it. Like, this lady, her social roles increased by 14.8 points. So MCID for a promise is 5. Right? So we're at 14.8 in one visit. So we do a good job? Yes. Right? But this is the thing, it helped me understand. It gives me a scope, a lens that really helps me narrow down. So I see my outcomes as a scope, kind of on a rifle that helps me really see clearly my target.
I'm going to challenge you a little bit because you didn't. So she scored very low. In social roles and responsibilities. Right?
Yeah, and self-efficacy.
Self-efficacy.
In everything. Yeah.
So, well, all of them, right?
Yeah.
So kind of our classic. Chronic pain, challenged. But you didn't target any of those.
No.
You didn't go and say, okay, I see you scored low in here, and so we're going to work on self-efficacy.
Yeah, no.
You targeted her. What I remarked about the event was, I'll be transparent. I don't know if I would have won.
Yeah, it's a tough
because
one.
Her comment right away was, I have all, and from as someone in medicine, it didn't make sense to me.
Yeah.
Right, and it didn't make sense to you.
Yeah.
Because it's not physiologic that this necessarily would happen.
Yeah.
But you believed her.
Yeah.
And went and I guess proved to her that it wasn't these things that were medically significant.
Yeah.
And so how did you know to go there right away?
Yeah, I that's a good question. I think that one of my I'm giving away a secret.
Yeah, excellent.
I don't like giving away secrets. But I do a pretty thorough exam. I do a thorough history. I read people's history and I can understand it. And I think that IQ comes from working in primary care and working with providers or physicians who, as you and I both know, they're smart.
Oh, yeah.
So I've learned a lot from being in primary care. I can read. I can read I think she had 30 some odd pages
something like
history,
that, 40
right?
something.
Yeah, 40. Maybe it was in the 40s. I don't know. We're getting a lot of 30 and 40 page histories, right? So I was able to screen and review the history very quickly, and then be able to then look at her promise and her MSK tool, and I was able to then kind of understand what was going on. But when she sat down and she said to me, I have pain so bad and it's worse than it was last week and I'm swollen all over.
Right.
I knew that that the pain education or exercise might have flared her up even more or gotten her upset.
Yeah.
So I asked the group that was with me, since we're in clinic, and they didn't really have a hypothesis. And I said, well, what causes swelling? And they said congestive heart failure. And so she's of the age and her BMI was high enough that we said, okay, let's take vitals.
Right.
And I saw this relief in her face when we started taking vitals.
Right.
Like, oh my gosh, they're doctors.
Right.
They're doing doctoral things. I think she thought, honestly, that we're going to put a hot pack on her. I thought,
put her on the treadmill and make her work or
something else. When we started taking vitals, I saw her take a huge deep breath. And it was just at peace, like, okay. Like, they know, because she was catastrophizing.
Right.
And we were like, okay, the number one thing we have to do is we got to see if this is an emergency or not. And the way that you know it's an emergency is you start taking objective measures. And my students were really shocked because her heart rate and her blood pressure were normal.
Right. So did you know, based on her response to that you were onto something?
Yeah, because she was at ease. Like before that, she was in a panic.
Right.
I mean, her eyes were dilated. She was sweating. Her eyes were shifting. She kept touching her body, doing repeated rituals. So one of the things, as you know, I always do is I'm always observing the person, right?
Yeah, right.
So I'm watching she's heightened.
Right.
And so I'm thinking to myself, how can I diminish this response because that's affecting her pain?
Right.
Right? Because we all know that. It was a physiological response to that. It's going to be heightened pain response. And you can't talk someone out of it when they're under catastrophe. You know, right?
Yeah,
Well,
we'll get back to the story, but I think some of the failures in primary care, because you asked me that question, why did we not jump on that, the pain education bandwagon, and just a few losses.
Yeah.
It worked for very few people.
Yeah.
As a matter of fact,
Yeah.
and I don't know, I might be giving it more, deserve than it needs to be. I don't know that I've seen it work.
Yeah.
And so
Traeger's article has shown that as well too, right?
Right.
That versus just being intent to listen to a patient through, right? For 2.5 hours of giving education doesn't really make a difference, right? So Traeger's article has already told what you've been doing or we've been doing as a group.
Right.
We understand that we have to make sense of pain, but I don't think that's an education always. Sometimes it's understanding, neural anatomy or physiology
or something that could link those two together.
That's right. So making sense of pain is not pain education. Making sense of pain is putting things together. And what her thing was is the fact that we went to the next stage when we recognized that she wasn't having arrhythmias or she wasn't having heart failure, is the fact that we recognized that the metabolic system can do the same thing. And so we knew that she had diabetes from her history. Yep. So going back to metabolic syndrome, she had that.
Yeah.
So we were able to then look at diabetes. And then that's when she told us that she has out of control diabetes. I think her A1C is like 7.6 or almost 8. But she's been having a hard time regulating.
Right.
So she's at 70 at one point, and then she'll eat a piece of candy and eat some type of artificial protein, not natural, and then she'll then spike to 180.
Right.
And so when we helped her connect that diabetes can actually affect pain. Right. That blew her mind because in her framework, she never knew that.
Right.
She believed that diabetes was a separate problem from her pain syndrome or her pain because she has all these other things. And we know that that's not true, right? That they come with all these things. And the thing she's been struggling the most is actually the diabetes part. And so we were able to help her understand that. And one of the big takeaways, because we always believe in an action plan, is how are you going to regulate it?
Yeah.
And so, measuring your blood sugar is the number one thing, and she was having a very hard time doing that. And so we have given her assistance by giving her text messages.
No, that was brilliant. The number of people that you have done that with in our clinic is not trivial.
Yeah.
It's powerful when I don't think from a patient's perspective, it's not just a reminder call from a robotic service, right? It's not just your dentist calling for your appointment or you've missed this. It really is follow through and follow up with that patient, and I have to believe that was helpful for her to realize that we're serious about getting her some help.
Yeah, I remember today we discussed it, and a student asked me they thought I was pawning it off to my students, and they said, Dr. Kang, do you text the patient? And I said, yeah, I actually do Saturday and Sunday. And I said, I'm extremely busy. Right. But for me, it's like you have to lead by example in certain things.
Right.
So, yeah, right. I mean, how can you not, how can you say to your student, go do that when you're not willing to make the call or make the text? And it's interesting, I said to her, because she also did a great job with her physical performance. We give her sit to stands to do, and it's funny, I remember we give her ankle pumps, which are very low level. I mean, metabolic rates probably 1.1 to do an ankle pump, right? But I told her, if you don't do these, then I know you won't do the rest.
Right.
Because it's the easiest
Wow.
one to do.
Wow.
See, that's the really thing about PTs. I think that's really stupid, is that we expect our patients to always do the hard exercises because that's what we tend to like. But most of our patients find that the hardest exercises are almost impossible to do. So what I look for is, if I'm looking for change, like in behavior,
Yeah.
I want them to do the easiest one first. So ankle pump takes no met level. So if they're not doing ankle pumps, I know they're not doing long arm quads.
Right.
And if they're not doing long arm quads, they're not doing sit to stands.
Right.
So that's how I usually grade it. So she said to me, I did the ankle pumps. I said, good for you. And then she says, I did long arm quads. And what I do with long arm quads is I make them do until they can't do anymore.
Okay. Yeah.
So they'll do like 20 or 18 or
Right,
24.
right.
With her, I think it was 12. And then she did sit to stands. And this is what I do with the sit to stands. I said to her, I don't think you're ready.
I love how you play chicken with patients.
Right.
I've seen that so many times when sometimes you'll say you're ready and jump off the table.
Yeah.
And then other times you say, I don't think you're ready. So how do you know?
So the thing is that I don't. It's a social experiment.
Okay.
I don't know what she's going to say.
All right.
She looks at me, and then she looks at me, she's like, oh, I know. It's a tough one. And I said, it sure is. And then she goes, well, I did 6. I said, yeah, you did 6 in 30 seconds. That's pretty good, but I don't think you're ready to do that as a home exercise program. And she goes, well, maybe I am ready. I said, so how many? So then I flip it, and I said, how many do you think you can do? And then she goes, I think I can do 5 at home. And I said, well, how many sets of 5? And she says, 2 sets. And so she comes back, and she goes, I've been practicing.
Right.
So I didn't make her do the ankle pumps or long arm quads. You know why? Because if she can do sit to stands,
Right.
then I know she's doing them. Because she
Right.
told me verbally. I
Right.
believe her.
Right.
So then I test her. Because we all, I mean, even though we say we hate to be tested, you know, like testing is one of the ways to reinforce. So I said, okay, we're going to do 30 seconds sit to stands. Right? And remember, this lady's BMI is like 47, 48.
Right. And this is visit 2.
Visit 2, she has all these things. So she says, okay. So 6 was her record last week. She gets 9. And you should have heard the room. The room was cheering her on.
Right.
And so she was exhausted. And then we asked her if she could do a 2-minute walk test. So she barely does 2-minute walk test, comes back, and then Hauk's in the room because Hauk wanted to train with us. And Hauk says to her, like, how do you feel? You seem really sore. She was touching her back and doing all these things. She goes, I feel great.
Right.
Because I'm not worried about the pain. I've got to push on because I have these other goals.
Right.
And so she has these wonderful goals about wanting to be with her grandchildren and get healthy and do these things. And she's like, I know that it's like I'm just going to have to deal with the pain. And I believe what's happening, besides her social roles increasing before, everything's increasing, is that she's building resiliency.
Yeah.
And you and I know that. And so building resiliency is part of, I think, is part of thriving, right? And she didn't, at that point when we had her, she was like catastrophizing.
Right.
So catastrophizing to resiliency can happen if you get around what the patient needs at that moment.
Right.
So was I targeting all these other things? No.
No.
I was targeting what the patient needed and using our clinical decision making to help her along that process. And all that training has helped us recognize like what she needs, but also what are the outcomes telling me. So it's a feedback on that way, and closing the gap or closing that loop. And I think a lot of therapists, they see the scope, but they don't know how to close that loop. Or for me, without closing the loop, I think that I would feel unsatisfied with my work.
Yeah.
That's why I love it. I've been, I've had every single job, assistant, aide,
right,
MPT, DPT, except for I don't have a PhD, right? That's the only thing I haven't had. But I've had every single job. And the thing is, Tyler, it's like, I don't know how PTs give that away to like close that loop to see where the patient's at. It's not fair for the patient, but I don't think it's fair for the therapist. That's why it's like my model has always been, I don't mind having an aide or an assistant. My clinic didn't have it, as you know, but I don't mind having them, but I just want them to be used appropriately.
Right.
And I would tell you, I'm getting so many aides who come and they just complain to me about their physical therapist and how they're seriously doubting doing PT because they feel like they're being overutilized and that the physical therapists have job burnout.
Right.
It embarrasses me.
Yeah.
You know that. It embarrasses me where we're at
Yeah.
and the way we're using aids, especially. It really embarrasses me as a profession. I think it's one of the worst things. Would you make an MA do that if you're a physician?
Right.
Right? Think about that. Would you do that? Would you allow some of the things that we're doing for the PT? I mean, that's because we work with physicians there all the time. The physician doesn't use the MA that way, and we shouldn't use the aid that way. It's unfair. And so I think there's some taking back we need to do. And and maybe this is just my weirdness. I'm just gonna put it out there. I'd rather get paid less and to close that loop. I would, than to make more, but feel like all I'm doing is
Counting reps.
writing reports.
Writing reports.
Doing
Yeah.
evaluations.
Yeah.
And I guess that's why I was a successful business owner and also one that's no longer in business right now. But I do have that entrepreneurial spirit.
Right.
And I think that helps us, you know? You never asked me to check that out, you know?
Right. Yeah. It does help us, and you've been helpful for how we want to brand and look at the future, and with more schools coming to Oregon, and the impact that's going to have, and the rethinking how we're doing clinic. So I feel bad for the alumni because we're making this place hopefully better every year, and so we're bringing all first year in-house clinics.
Yeah.
Well, all first year clinics in-house.
Yeah.
So they can train with the best.
Yeah.
You and JD and Lisandre and Jeff, and that's going to be really powerful for us not to let someone else do the training. But have students experience what it's like to train the George Fox way.
Absolutely.
Yeah.
Hey, so I love that topic, but I've been thinking about something that maybe we can start closing down on. It's just the alumni, right? I've been thinking a lot about them.
Yeah, me too.
Because I get calls like you do. You do more than I do, but I do get calls a lot. But I've been wondering about like the 95% I don't hear from.
Yeah.
And it's like, how many have we graduated? Like how many cohorts? 7, 8?
6 cohorts have graduated. So
Wow.
if you do an average, 6 times 4 is 24. So 240, but we've not always had 40. So,
Sure.
220, maybe 230.
Yeah, I mean, I'm always interested in like knowing what's happened, right?
Yeah.
But it's also like, how do we close the loop on them? Because I feel like there's so much that we can do. I don't have any solutions at this point. I guess it's more of a desire, a hope.
Yeah.
Right. I mean,
that's great. I'm with you. I mean, I want them to shout out to you and me and JD to say, listen, this is what I miss badly.
Yeah.
This is what I think I need as a a growth step for my profession.
Yeah.
Whether it be helping them jump, whether it be helping them with tools to be able to do a little bit better job of practice, whether it be to update their knowledge base with research.
Yeah.
One of the things that we're teaching things now that our first cohort didn't get.
Yeah, for sure.
And we're teaching just the clinic example that we just brought up. None of the previous cohorts were able to spend a month with you.
Yeah, sure.
And so I feel bad.
Yeah.
For but that's just we're growing as a program, and really doing. I think we're listened to our alumni.
Yep.
We get letters and some positive, some negative,
Sure.
and we take that, and we're serious about listening to them and wanting to really create a great program for them.
Yeah.
And so you're right. I want them to shout out to us to figure out how are we able to help them, continue to help them grow as therapists, love their job, want to continue in doing that, and how can we give them some tools to be able to jump, if they need to jump, but what if they all started primary care in their clinic?
Yeah, absolutely.
And that would be really cool to practice in a different way.
Yeah.
To kind of give them some, so interestingly, it gives you tools to practice. In a traditional role as a therapist. So I know that's what it did for me. Being embedded in primary care, and then then treating here. I do still see patients
Yep.
occasionally,
Yep.
and so but it allowed me to kind of think, to train
Yeah.
a little bit different.
Yeah. I mean, I don't know if JD can speak into this, but I've been thinking about, it's like I hear a lot of people not interested in the way that healthcare is going, and I understand it's tough. It's tough. I mean, I watch. I do practice, as Tyler knows. I practice still, and I see it, firsthand, how tough it is. But I don't understand why more PTs, especially our alums, aren't trying to change the norm way it's being practiced. I know that there's groups that have gone to cash pay and all these things, and I know a lot of our alums are now directors and they're CIs. I really appreciate that.
Oh, absolutely.
But it's like I'm just thinking about what does it take for us to actually look at value-based care. I know if you and I've talked a lot about that. We
got a good project, I think, coming up
Yep.
that you'll be involved in. But I think a project with a large insurance company.
Yeah.
To be able to see if value-based care is what we think it is.
Yeah. So I'm just interested in having dialogue with our alums who are on the front lines, because I'm sure that they have a lot of insight or questions or just
let's commit to this then. We should have a Saturday then.
Yeah.
I'll commit to that.
Yeah.
And I'll rope you in.
Yeah. Yeah.
And Jacobson and I saw JD raise her hand. But we should have a Q&A, or brainstorming session, or just a BS session around how can we, what kinds of things can we do to, listen to them and figure out maybe collectively together how to band together, and then how to influence practice. I know people are doing that one-on-one. I know people are bailing, from some of the clinics that they're, because they're not happy, with the status quo. They're not happy with practice patterns and making them see patients 12 times when they can get them done in 2 or 3.
Right.
So let's do that. Let's set up a time, in the next couple months maybe.
Yeah.
We could also do a Q&A where we have people send in a question or
send in a question. We could do So we could even do You
could ask them to answer on the podcast.
Yeah, so that'd be great. Can you do podcast live? No, we'd answer the questions later.
Yeah.
That's what JD says.
So
that would work great. Send in questions. We could answer them, or I like a face to face. So we could do face to face, but then people beaming in.
Yeah.
That maybe can't be can't be here face to face. I'd love to hear their struggles. I'd love to see if we could help them affect change.
Yeah.
Yeah.
I think really building community. I don't even think it's networking, but building community will help us, right? I mean, it's such a strong way, and I think that you're right. I think unifying that will be huge versus just having some of these side discussions with everyone.
Yeah,
I would love that.
Let's do that. Let's commit to that.
Yeah.
So here's just a story I think that will solidify that.
Yeah.
So I was at a corporate level presentation, and so there was a bunch of corporate directors and PTs there, and so I was showing them some diagnostic ultrasound of Achilles. I did a kind of a tendinopathy talk, patellar tendinopathy, Achilles tendinopathy. I brought a portable one in, and it was great. They were playing around with them, and I had this injury. Can you find it? And looked at someone to see if they were pregnant. I mean, just fun stuff with diagnostic ultrasound, right?
That's cool.
And then someone asked how much it was, and this happened to be $25,000.
Yeah.
And they said, oh well, then the clinic could never afford it. So I looked at the clinic director, because they had about 8 therapists there from one shop, and I told them, you need to plug your ears because I'm going to say something.
Yeah.
And I said, you 8 therapists make this one corporate office, this one clinic, $1 million cash.
Yeah.
You each give them $150,000 a year profit.
Sure.
And if they can't buy you a $25,000 piece of equipment, that's their fault.
Yeah.
And it's your fault for not banding together and actually asking for one.
Yeah.
And I think we're at the time, and that's a solution. We should band together instead of running around with a sign, and shouting that this is crap and this is horrible and I'm bailing. we should band together.
Yeah.
You know, and this may be that time where we're creating community,
Yeah.
like you said, and a community of believers,
Yeah.
if you will, in the way that we think practice should go.
Yeah.
This might be the start of that.
Yeah, I agree. And even if you're not an alumni of our program, right, but just listening to the podcast,
Yeah.
we would still invite you.
Oh,
right?
absolutely. Yeah,
because I think that we have people and just friends and other partners who are interested in partnering with us.
Yeah.
That we would love that as well too. I mean, again, my heart has gone out to lumps just because as a professor, I've always wondered what's happened.
I'm with you too.
You know,
I mean, my heart goes out to them, and I want to make sure that we're continuing to do a good job, or what we can for those alumni that are interested.
Yeah, I'm actually as interested in that than recruiting people who want to come to our program.
Right.
I mean, I think we have great faculty who are interested in that, and Christine is great at that.
Yeah.
But I'm probably more interested on the backside and making sure that the alumni are looped back into the things that we want to do.
Well, I see your what gets you going. It's some. I can tell. It's mentoring.
Yeah.
100%. And so I think that's going to be an important piece of being able to do that. So. And maybe that's part of what we can do. What we can give back, to alumni is mentorship opportunities. In a more structured way, and bringing them in and running a clinic on the weekends. And treating together. And that actually sounds pretty fun. Yeah,
it will be a lot of fun, and we know we have a lot of patients who want that.
We do have a lot of patients,
and I think that's the fun thing. And I think I feel like I just can't wait. So I don't know if you're listening to this podcast. I really hope that you, find it, helpful to you. But honestly, do something about it. Yeah. Like Tyler's, charging you, saying, "Hey, we're going to do this, right?"
Ping us. I'm serious. Yeah. You have our emails. You know by now. So. Yeah, do it. Ping either Dan, myself, or JD, and say, listen, this is. I want a part of that. I want something to help me in clinical practice, whether it be jumping, whether it be kicking the door down for you and helping you jump, or just giving you tools to practice. As a clinician, synthesizing articles for you, so you're not having to read at night. Because of all the other stuff that you're doing. So. Love to put our money where our mouth is and model that.
Absolutely. I remember that day so well when I was coming and I saw the banner pop up with George Fox, and it's like yesterday, literally. I remember what I was doing. I remember driving into my clinic. It was like 10 o'clock, 11 o'clock, and I saw your name, Tyler. And I hope that some of the alumni or people who are listening to this feel the same way. Like, this is it. Like, this is the call. Don't wait. Because I do really wonder that sometimes. Like, what would have happened if I just let it slide? Yeah, well, it's like, it's like I felt like really like God was kind of speaking to me about it, It's like he knew the heaviness of my heart. He knew what was happening internally, like literally, like this, all of this stirring in my heart. Like, what am I going to do? And I think to myself, I'm so glad I picked up that phone and cold called this guy. And, I think we've been together now for 8 years, been here for 8 years now. Yep. And I would say it's been life-changing. And so I don't know where people are at. Maybe that's happening to them. I just don't want them not call in.
Not to reach out.
Yeah, maybe this is their moment, right? Like it was for me.
That's cool.
Just call and reach out. And I think that's what I keep thinking about. It's like I think there's so many people who want to, and for whatever reason, it's just so hard. Yeah. Because it's weird or I don't know what it is, right? But it's like, forget that. Yeah. Just do it, and just see what happens.
And if that's the jump for them, it's just to get a hold of us. Jump. Yeah. Yeah. So give us a call.
Yeah, I think that's exactly what it is. Yeah.
Cool.
Yeah. Awesome, man. Well, thanks for this time. I'm glad
well, thanks, Danny.
Yeah.
Yeah. This has been great.
Yeah.
And we'll get into some richness of some articles later and practice patterns and behavior and but I think for now, just kind of introducing the goal for these is to link our alumni and others that want to continue to drive the profession forward.
Yeah. 100%, man. Behind that. All right. Well, thanks.
All right. Well.